fibrosis of the heart. That one's the
Okay, whenever you're ready, take it away.
Okay,
Well, good day. I don't know if it's noon or morning in your part of the world right now, but thank you so much for inviting me to speak on heart failure. It's a surgeon's perspective because I'm a cardiothoracic surgeon at UAB and have a special interest in mechanical circulatory support and heart failure. So I can't talk about heart failure, which is an enormous topic that people dedicate their entire professional careers to, but I can't talk about it without mentioning the non-surgical therapy. So we'll move right along. I do have conflicts of interest. I'm on data safety and monitoring boards for Medtronic and Abbott, actually for non-heart failure devices at present. And I wanted to publicly thank the team members because this heart failure care is clearly a team effort. Salpi Pambukian and Jose Talaj are the leaders of our heart failure service. They helped me with the slides and references for this talk, but I also wanted to reach out and say thanks to the many physicians, nurses, physical therapists, respiratory therapists, anesthesiologists, intensivists, and others who participate not only at UAB, but other hospitals across the United States, and especially in our region, to collaboratively work with us in the management of heart failure. So the objectives of the talk today: first, we'll define heart failure and the systems for categorizing the etiology and severity of heart failure, discuss the pathophysiology and non-surgical or medical management, and then we'll get into something that I really do know a bit better, which is mechanical circulatory support devices for patients with acute or chronic severe heart failure, and then briefly mention the next step in the development of mechanical devices. So in terms of definitions, the American College of Cardiology and American Heart Association define heart failure as a complex clinical syndrome that results from any structural or functional impairment of ventricular filling or ejection of blood. And so it's a cardiocentric problem, but it affects every part of your body, which is an important concept in diagnosing and especially in managing these patients. The European Task Force on the Diagnosis and Treatment of Acute and Chronic Heart Failure defines heart failure clinically as a syndrome in which patients have the typical symptoms like breathlessness, ankle swelling, and fatigue, as well as signs like jugular venous distension, pulmonary crackles, and they say a displaced apical beat, which is a nice way of saying cardiomegaly, resulting from any abnormality of cardiac structure or function. The scope of heart failure in this country is stunning. This particular slide is actually several years old, but you see the prevalence of the disease and incidence. There are 870,000 cases every year with a 50% mortality at 5 years. It's one of the most common discharge diagnoses in the country, and the cost is in the tens of billions of dollars. So it's a major public health problem that results in substantial morbidity and mortality. It is a bit of a first world problem, but is seen certainly in other environments with projections up to 70 billion by 2030. The classification, there are several parts of, when you talk about heart failure, there's a lot of jargon, which is ill-defined words that we all use because we think we know what it means and everybody else thinks they know what it means, but you can often miscommunicate as a result of thinking you know the definition. So the stages of heart failure from the ACC Foundation and the American Heart are A, B, C, and D, which actually overlap with the New York Heart Association functional classification. So the stage A is your risk for heart failure. At B, you have structural heart disease, but without signs or symptoms. So you're still class 1 from a functional standpoint. So class C, or stage C, is where the action occurs. You have structural heart disease with prior current symptoms of heart failure, which go from, you're compensated, so you're essentially doing anything you want, up through class 4, which is unable to carry out any physical activity without symptoms of heart failure or symptoms of heart failure at rest. In stage D, which is where we have many patients in our heart failure service and in the heart transplant unit, you have refractory heart failure that requires specialized interventions that we'll talk about during the course of this presentation. And those patients are stage 4, unable to carry out any physical activity without symptoms of heart failure or symptoms at rest. So there's a lot of overlap, and when you're talking about a given patient, keep that in mind. So this is an old paper. It's a review that was in the New England Journal, but it's a wonderful review. It has limitations in terms of current information, but it was one of the first I saw that really educated me about the systemic nature of heart failure. So if you look at the diagram, there's a dilated heart that can be treated in various ways, and there are a lot more in 2021 than there were in 2003. But the point is the heart failure also affects the vascular system. You can't see it, but the inflammatory system is revved up. In patients with advanced heart failure, and there's something called the cardiorenal syndrome, which has become recognized as one of the most prominent aspects of the heart failure syndrome, and is really quite difficult to manage when it becomes established. So jump out for a moment to a paper, review paper that was in Circ in 2018 that specifically addressed right-sided heart failure, but they had a wonderful slide in there that showed in a cartoon sort of way the pathophysiology of the cardiorenal syndrome. I mean, how does that happen? How does the heart failure lead to kidney failure? Well, first of all, many of the patients have intrinsic renal disease to begin with. So maybe diabetic with diabetic nephropathy, and then superimposed on that is the back pressure from an elevated CVP, activation of the renin-angiotensin aldosterone system, the sympathetic nervous system with vasoconstriction, decreased renal perfusion, release of natriuretic peptides, that's the inflammation, the bradykinin, et cetera, that ultimately causes a decrease in renal function that at some point can become fixed. We then recognize that there's also a cirrhosis associated with chronic heart failure, which can be so severe that it limits the ability of the team to treat the patient. So if they're young and they have had congenital heart disease with a Fontan procedure, chronically elevated CVP, their liver becomes cirrhotic and has no reserve, or they're in liver failure, then you end up doing a liver heart transplant. And there are instances, albeit rare, where they get a liver, kidney, and heart transplant, all because of the systemic nature. The primary culprit is the heart. All right, well, let's jump back to the Jessup paper as a review from the New England Journal in 2003. A couple of terms, or more than a couple, but a few terms that are bandied about in heart failure. You've got predominantly left, right, and biventricular failure. It's oftentimes hard to tell between the two, or between the three conditions, because there's so much interplay. The ischemic versus non-ischemic cardiomyopathy. So the top image there is ventricular remodeling after an acute infarction. In this case, it's an LAD infarction where you have anteroapical scarring with expansion and eventually global remodeling of the heart that gives you the dilated, poorly contractile heart in the final slide there. The other type of ventricular remodeling you can see is a hypertrophied heart, so chronic hypertension, and eventually the heart will dilate and oftentimes will thin out a little bit, but that common pathway of a dilated, systolically impaired heart is the end result, no matter how you got there. The concept of systolic versus diastolic dysfunction confused the heck out of me when I was young and first reading about this. But some of that confusion's been resolved by what people have written about in the last, 15 years or so, talking about heart failure with reduced ejection fraction versus heart failure with preserved ejection fraction. So that's kind of the jargon of the day, and it's important for you to understand that, because doctors, cardiologists will bandy that about, and you sort of like, what are they talking about? Because they don't say heart failure with reduced ejection fraction, they say HFrEF. So HFrEF is reduced, HFpEF is preserved, and the break point is around an ejection fraction in the left ventricle of about 40%. And that's where most of the randomized clinical trials have enrolled patients with HFrEF, reduced ejection fraction. And the interesting part, and this is a part that really confused me, well, not so much this, but the fact that HFpEF, and I'll mention in a second, has so few recognized therapies, basically none. But HFrEF, the tremendous number of things you can do to help these patients. So what they say in here is it is only in these patients, the HFrEF patients with reduced ejection fraction, that efficacious therapies have been demonstrated to date. That was written in 2013. 8 years later, it's about the same. There's a gray zone in, so you can have HFpEF borderline where your preserved ejection fraction is not that great, it's 40 to 50%. And then you have HFpEF where you're improved, but you're really a HFrEF patient. So, and these are important to recognize. There are some patients that come in with a terribly reduced ejection fraction, are put on a good medical regimen, they do everything right, they cut their salt intake, etc., and they come back and get another echocardiogram and their ejection fraction is now 45, 50%. They still have HFrEF, but it's improved, and it's important to recognize that. If they're really HFpEF patients that are failing, that's a different group, and they don't do nearly as well. So it's been the last sentence in the heart failure preserved ejection fraction. To date, efficacious therapies have not been identified. I think the heart failure cardiologist would quibble with that, but in general, they're difficult to treat, and especially if they have a small ventricle, because it's basically transplantation or nothing, because it's hard to put a left ventricular assist device into a normal size left ventricle. So back to Jessup's paper, this was a wonderful illustration that has more options now, but is a great way of displaying sort of intellectually the stepwise thought and management of patients with heart failure. So you start out with patients that are high risk but are asymptomatic, that then move up into structural heart disease but no symptoms. Then they start getting symptomatic, so you begin adding ACE inhibitors or ARBs, angiotensin receptor blockers, and beta blockers, and ultimately diuretics. Digoxins kind of goes in and out of fashion. I don't see it that much in the patients that are in the heart transplant unit. Cardiac resynchronization therapy, mitral valve interventions, revascularization. Then you see where they consider a multidisciplinary team. I'll talk to you about that in a few minutes. But it's not far from there to inotropes, a VAD, a transplant, or hospice, because there's nothing else you can do. And I guess after that, you're off to heaven, you hope. But it's a good way to think about a patient because you can mentally put the patient somewhere on that staircase and begin to think about what's the best therapy for them. You don't want to throw the kitchen sink at somebody who's only got risk factors and maybe diabetes. It's inappropriate. So the heart failure syndrome has a number of etiologies. Most commonly, the ones I see are ischemic. That's by far and away the highest, then valvular, and then you get into things, and valvular is long-standing valvular heart disease, mitral insufficiency, aortic insufficiency, etc. Infectious could be endocarditis, but that's really valvular. I think more common is acute heart failure that's part of a sepsis syndrome. There are some autoimmune syndromes. We think postpartum, that's not really been well worked out, and probably some viral, but there's also probably some virus. Some viral cardiomyopathies that, which is really the end result of myocarditis, the direct infection of the myocardium. A lot of genetic disorders we see, as they say, not uncommonly, that's a double negative. It's pretty common to see a patient with what we call idiopathic dilated cardiomyopathy, so I don't really know the etiology, but you ask, do you have any other blood relatives? Oh yeah, my cousin and my mother's sister had the same thing, and you transplanted one of them. And I'll go, oh yeah, I guess that's probably familial. The arrhythmic cardiomyopathies are related to long-standing or persistent tachycardia usually. The idiopathic, well, you never really know. And then there are others that are related to, acute dissections, which you could consider, I suppose, a combination of valvular and ischemic, pulmonary thromboembolism, hypertensive crisis, thyroid dysfunction. Postcardiotomy is the category that is been persistently difficult to treat since I was since I was a first year new on the faculty, that it's still about a 30 to 50% mortality, or 30 to 50% survival, so 50 to 70% death in patients who have severe, really profound cardiac failure following a cardiac operation. But I mentioned before that cardiomegaly occurs in part of this common final pathway in most, but not all patients. And there's this clinical syndrome of heart failure that it's useful to recognize. So I wanted to put this in because I understand there are many people here involved in primary care. This set of guidelines aren't specifically directed at heart failure, but ultimately they are. And it's a reminder about the subset of acquired cardiovascular diseases, largely atherosclerotic, that can result in heart failure. And that many cases of heart failure can be avoided or delayed for years. And it's really tragic that they're not. So like Benjamin Franklin said, in the 1700s, an ounce of prevention is worth a pound in cure. So these guidelines were published it was the American Heart Association in 2019. They're easy to find. And they go over in a little more detail than you've probably thought about for a while exactly what you should be telling your patients. And they have on there the level of evidence, which is useful because they'll tell you where they got their information from to make the recommendation. So let's say a team-based care approach is recommended. That is modern medicine, the best modern medicine. You don't bounce them from one person to the other. If they can be seen by a group that works in close collaboration, not necessarily in the same clinic, but they do work closely, you'll get your best result. And the things like exercise, and they define what exactly that means. Not everyone can exercise, but they do have recommendations there. Nutrition and diet is important, and there's some things that you would have thought would be no-brainer, randomized clinical trial level of evidence and they're not. they're lower than that because there's still a lot of unknown about what is the optimal diet. I mean, if you watch infomercials, you think it's all figured out. But if it was all figured out, you wouldn't need infomercials to begin with. The general recommendation is for a diet emphasizing intake of vegetables, fruits, legumes, nuts. We all know that. There's also a section in here on the optimal treatment of diabetes mellitus, which is essentially reaching epidemic proportions in the U.S. In talking about how best to control it, and it's an area that we're still learning about. So, I'd say stay tuned. If you want to know more about best practice guidelines, if you go to PubMed, it's the search engine for the National Library of Medicine, and type in your topic and best practice guidelines, it takes you to the best information that's available right now in various areas. So I'd recommend that. There was a interesting update this year on the existing best practice guidelines, the consensus decision pathway for optimization of heart failure treatment. And I'm not going to kill you with the 10 pivotal issues. I just wanted to show you the current algorithm for therapy because I had not really focused on this for a while, like a few years, and it's a field that's absolutely exploding. And we were just talking about this, the drugs that have become available with really strong evidence of efficacy. And that's fine. I'm glad we have the drugs. But it really complicates management because it used to be someone was identified with heart failure and you say, okay, we'll start some Lasix, maybe some spironolactone. We'll make sure you're on a beta blocker, your cholesterol is controlled with a statin, and start you on an ACE, and we'll call it a day. That's pre-ARB. And now you can see the level of interaction in those red squares. The green, I don't know what you call that, figure diamond at the top is your basic foundational therapy, which is also changed because now we have trade name is Entresto. It's sacubitril and valsartan, I think. But it's angiotensin receptor blockade with a neuroleptin inhibitor. That's the sacubitril. And then you've got combined with an ACE or an ARB, and it gets complicated because the side effects of these can really be awful. Angioedema being the worst. I've only seen a few cases at a distance. It's not something, fortunately, surgeons have to deal with too much. And they have also new drugs to help slow the heart rate in patients with persistent tachycardia despite treatment with beta blockers. They really won't tolerate any more beta blockers. To be honest, we haven't used that very much. And down in here in the second diamond on the bottom, the second from the far left, is the sodium glucose cotransporter 2 inhibitor that Farxiga, which is the one that I'm aware of that's approved, but there are about 4 others that are in the pipeline. So these are really interesting drugs that, here's the next slide. So these are, as far as I'm concerned, hot off the press, but it's not like I have my finger on the pulse of this as a surgeon. We get them off drugs. That's the whole point. Transplant, ventricular assist device, fewer drugs. But it was quite interesting to read about the SGLT2 inhibitors because of how they work. It's an area of active investigation. I thought it was as simple as more sodium and glucose go out the tubules in the kidney, and by getting rid of the sodium, the glucose loss is nice because you maybe lose a little bit of weight, and if you're a diabetic, it helps control your serum glucose. But it turns out there are a number of other effects on sodium proton exchange inhibition, or sodium proton exchange, progenitor cells that are beginning to bring stem cell or regenerative therapies into it. Your erythropoietin levels go up, sympathetic nervous system tone diminishes, which may be indirect. The NLRP3 inflammasome, which I know almost nothing about, but is an important part of the inflammatory response to heart failure, is toned down by these drugs. And then autophagy and mitophagy. I know a little bit about autophagy. I'm not sure I totally believe in it. But there is some turnover of cells in the heart, and these drugs may have a beneficial effect on that. So it's not just about sodium and glucose, but whatever the mechanism is, these drugs are another useful, effective, and reasonably safe tool to treat heart failure. So this class of recommendation, they don't have any twos on glucose co-transporter inhibitors, mainly because of the angioedema. So, we have pharmacists in the room with me today, and I'm sure many of you listening are people in primary care who may be thinking about using these drugs for the first time, know that especially with the angiotensin receptor blocker, neuroleptin inhibition, history of angioedema is really something to consider, as in if they have a history of it, they probably shouldn't receive it. ACE inhibitors have to be stopped for a period of time before initiating Entresto, because it's an angiotensin receptor blocker, as well as the other drugs that can exacerbate the angioedema. So be aware of that. The link between diabetes and heart failure I found quite interesting. I always thought it was simply the link between the vascular disease, but it's much more than that. And this also gets into the mechanism for the sodium glucose co-transport inhibitors, in that patients with, you see there are a number of mechanisms by which you end up at the purple box: heart failure and diabetes. Some of that can be straight up coronary artery disease, and I think having operated on a lot of patients with atherosclerosis, just straight up coronary bypass operations, the diabetic vascular disease is different than the non-diabetic vascular disease. But it also affects autonomic dysfunction, cardiomyocyte hypertrophy, calcium handling, fatty acid utilization, etc. So it's complicated, and the part that's a little simpler is that as your hemoglobin A1C increases, your chances of having stage D heart failure, limited life